Hello, everyone. Thank you so much. I'm delighted to work with Mark and Michael to share with you a little bit about the Virginia story. We have very much wanted to be a part of this work to improve value. It's what we do. Michael, if you'll go to the next slide. So let me tell you just first a little bit about the Virginia Center for Health Innovation and why we're positioned to lead some of this work in Virginia. We are a 501c3 nonprofit with a mission of accelerating value-driven healthcare. And we have a very diverse multi-stakeholder board of directors. Next slide. And I think this piece about us being a public-private partnership and the diversity of our stakeholder board is a really critical one for folks to understand. Because as I like to tell people, one, VCHI has no financial skin in the game. So we can work really hard to promote data transparency and letting the chips fall where they may. And so we're just uniquely situated. We were created by Virginia's governor as a response to what he had the Virginia Health Reform Initiative after the passage of the ACA, really with the recognition that in Virginia, the Virginia way would not be to drive this through state government, but would instead be to bring all the partners together to work on this. And so you see in this slide, our founding partners really covered the gamut from, providers, labs, pharma, health plans, employers, the safety net, the health systems, all engaged. Our founding chair was our Secretary of Health and Human Services, Dr. Hazel. Our current secretary, Dan Carey, also serves now on our board of directors. We were housed at the State Chamber of Commerce at our founding. We now, since we've grown, we are now housed at Virginia's Association for Federally Qualified Health Centers. Next slide. You can see here we have a board and an advisory leadership council, and I just give this to you so you get a sense of kind of the depth and breadth of our members and the input that we get from the front lines in healthcare in Virginia. Next slide. So the work of the center really covers 4 core services, but today I'm going to focus primarily on number 3, which is leveraging data and analytical resources to inform and enable healthcare providers, public health professionals, the government, community organizations, employers, and consumers to make better decisions. So this is that role of kind of bringing data to light to drive improvement in the Commonwealth. Next slide. So what did we do and how did we get involved in this work? When we were getting started, we felt it was very important that we choose as one of our initiatives something that crossed all interested parties. So unlike many states who focused their innovation work solely around the expanding Medicaid population, we were looking for something where we could build consensus across all insurance types, all regions of the state. And so we decided very quickly that a place for us to work on was reducing low-value care. There seemed to be a lot of interest by employers. There was interest and willingness to have the conversation by our providers. And fortunately, choosing wisely was at the forefront of the national conversation, and there seemed to be consensus around that campaign. We believed very strongly and still do that an initiative where the physician community had identified themselves those tests and procedures that needed to be addressed had the greatest likelihood of success. So, we started there with the identification piece. Then we went into measuring. How do we get the data? How do we know what's happening in Virginia? Because I will tell you from years as a performance evaluator of policy programs, I wanted to know what's the baseline and how do we know if we're making a difference. It's not just enough to launch a program and hope it does good. So we really wanted to make sure that we could measure. The next step for us was about reporting. How do we share that data? And I will tell you, I joke with Michael and Mark that I've switched the order of their 4 verbs here. We report first, and then we work to reduce, and then we will report again. So it is very cyclical, but we really had to work on the reporting as a third phase, and then finally to get to that reduction. How do we test different strategies? Because the truth is, as Mark shared with you, the different strategies, we don't really know yet which ones are going to be the most effective for particular tests or procedures that we're concerned about. Next slide. So I mentioned the first step, identify. This was really building consensus for us. Could we get everybody in the Commonwealth agreed that this was going to be a priority? And so I just list here probably about a third of the presentations that I did over a 1.5 year period of time to really go out, talk with folks about this idea of measuring unnecessary care in Virginia, building consensus that this is something we wanted to tackle. And the good news is that from all these different entities, the resounding feedback that we got was this is important. Next slide. So then measure. The question became, could we get that baseline data? Could we start to identify how much of this was happening? And this is where our partnerships were very critical to our success. So in Virginia, we are very fortunate that the Virginia General Assembly, the Virginia Association of Health Plans, the Virginia Hospital and Healthcare Association came together and worked with Virginia Health Information to launch an all-payer claims database. And at the time that we were starting to really want to get baseline data, that APCD was robust enough that we could use it as our data source. And so we used the state's all-payer claims database with the Milliman MedInsight Health Waste Calculator and looked at the claims data for 5 million Virginians. Next slide. So the data that you're seeing today is from version 6, which has 42 measures. We should have version 7 ready to go in about a month. We're super excited about that because I think, as Mark mentioned, that has additional measures, and that resource is only going to grow. And I think that's important for people to recognize. You know, if you look at the National Choosing Wisely campaign, there are over 500 tests and procedures that have been identified as unnecessary or low value. So we are looking at a very small portion of the potential. We are looking at ones that at least initially lend themselves best to claims data. As Mark shared with you, some of these, all these measures are clinically nuanced. Some will require clinical information that isn't available in claims data in order to really determine how necessary it was. So it's important to know that the waste calculator that we use really focused those initial measures on those that were, most applicable to claims data. And you can see there kind of where the sources for these measures that comprise the 42 came from. And again, many more measures in the pipeline. Next slide. So in terms of our data, you can see there's one of the challenges moving forward is there is a little bit of a data lag. So in January of 2019, we could release results through December of 2017. So there's about a year lag right now. We're working to shorten that time period. But I want to focus your attention on the last two numbers there. So just those 42 measures in Virginia, 747 million per year, and that represents over 2 million unnecessary services. Next slide. You can imagine those numbers, and we've actually been putting those numbers out now for 4 years. We started with 2013 data, and those numbers have been fairly consistent over time. Part of the road tour, if you will, that I continue to do is to let folks across the Commonwealth kind of kick the tires on the data, and to do a deep dive of that data. And the good news is that the data seems to be standing those tests. We have had state health systems compare a regional data analysis that we've done to their own data through their EHR, and it seems to be fairly consistent. So that's good news. Bad news, you can see in Virginia, 39% of members were exposed to at least one low value service. 35% of services measured were of low value, and that represents real money. That represents over $11 per patient per month in unnecessary claims. Next slide. So here you'll see the top 5 measures that we had, and this is by cost, and it's a proxy cost, but this is by cost. The thing I want to draw your attention to here is that first one. If you remember Mark's list of the National Task Force top 5, our number 1 is their number 1. This is the labs for low-risk patients before low-risk surgery. This is a big one, and this is the one in Virginia that we really are going to focus on. Next slide. So we're also able, we have lots of ways we can slice and dice the data here in Virginia. I just give you this as an example. We are able to run the reports thanks to our friends at Virginia Health Information by region of the state. And you can see there are some fairly significant regional differences. We have actually looked very closely at Southwest and Northern Virginia. Health systems in those 2 regions have actually asked us to do a deeper dive of their performance. And I can tell you, not only is the percent of members different, but the things that comprise the unnecessary services in those regions are different. Both have the same number 1, and it's the same number 1 that we have and the same number 1 that Mark has, that, testing and imaging for low-risk patients before low-risk surgery, but there are differences when you get, 2 through 10. Next slide. So, after we started running these reports, we get to step 3, which for us is the report, really sharing that data. And some lessons I would share with you all if you are considering doing this in your state or in your organization. It's really important that you think about the audience that you're talking to. And I have learned this the hard way as kind of the pioneer speaker in this area. So if you are speaking particularly to physicians, you don't want to talk about waste. They get very unhappy if you are suggesting that they are doing wasteful things. If you talk to them about low value, that they might make better choices, the receptivity changes. So we're very cognizant of that. I will tell you, employers, it's kind of the opposite. Employers use the word waste, and now they want to sit down at the table with you and they want to identify that waste and eliminate that waste. So, it just depends who you're talking to. Similarly, what I have learned is that not everyone's first concern is tackling the top 5 by cost. That's how I initially approached this. You saw my top 5 list by cost, but I have had very good conversations about different ways of approaching this. So for example, our state employee health plan, when they first reviewed data, they said to me, cost is important, but we want to show our employees that we want to focus first on reducing harm. And so of those measures in your 42, which ones have the potential to cause the most harm, and can we focus on those first? That was a great argument. Similarly, when I shared this data with the chief medical officers of several of Virginia's leading health systems, they said to me, well, harm is important and cost is important, but if you want to have a win, we think it's important that you choose tests and procedures that we are performing inappropriately the majority of the time. So for example, you could have something like an EKG, which is expensive and shows up as a top cost, but 97% of the time, clinicians are getting it right. They're ordering it correctly. You could have something, and I'll select Dr. Fendrick's favorite vitamin D screening, that's not nearly as expensive, but it is being ordered inappropriately a great deal of the time. And so their message to me was, think about choosing things that aren't needles in the haystack out of the gate. We've also learned we have to be prepared to address provider medical liability concerns. So, the good news is that all of these things come from, evidence-based medicine, from approved best practices of the medical specialties themselves, but it's really important that you arm providers with that information. And then some of these measures, consumer education is going to be a bigger piece than others. If you look at the full list of 42 measures, you will see some things where consumer behavior is going to be more relevant. Things like requesting antibiotics or imaging for low back pain. That's much more likely to be important in those cases than perhaps in some of the labs that are ordered before a low-risk surgery, or for PICC lines for in certain medical cases. So you typically don't have patients asking for those things. So again, your approach is going to vary based on who is influential in asking for that service. Next slide. So I am not a researcher by training. I am a convener. I am a policy person. But as we started to get this data, my peers, Dr. Maffei at UCLA, Dr. Fendrick, and our team here in Virginia decided it was really important that we start to get the word out. And so we submitted a piece to Health Affairs, and we were delighted that it was the third most read article in 2017. And so that brought additional conversations about what to do. Next slide. So as we started talking more and more about what were we going to do to reduce low value care, I will tell you that one of the concerns that was most frequently raised was, well, what happens if you do a great job of reducing all this low value care? You create the headroom that Dr. Fendrick is talking about, but none of that money gets reinvested, right? That money all just gets pulled from the system, and then we're going to feel very defeated, because while we will have done a little bit to improve value in healthcare, we won't have done as much as we could do if we reinvested some of that funding back into the high value care side. And so hearing that dialogue, we decided here at the Virginia Center for Health Innovation to create a health value dashboard. The health value dashboard is an attempt to really show both the importance of low value care and high value care services across Virginia. So if you go to the next slide. Okay, one more. So on our dashboard, we have 3 aims: reducing low value care, increasing high value care, and improving the infrastructure for value-based care. And I will tell you that third one is really important. When we first started, all the discussion was around those first 2 aims, until we realized that many of the measures we wanted to include under aims 1 and 2, we couldn't, because we didn't have the ability to measure the things that we wanted to measure. And so this piece about the infrastructure is really important. The other thing I want to share with you is that it took a lot of hard work, and I want to thank my board and advisory leadership council, which represents about 50 some organizations, to have as few things on this dashboard as you're seeing. Because as you can imagine, we started out with a list that was in the hundreds of things that people thought were important to include on the dashboard. And my mantra here at the center is, people cannot move the needle on more than a handful of things. And so these are our handful of things. Next slide. So on the low value care side, you'll see there's 3 there. The middle one, B, is really this piece that we're talking about of low value services captured by the health waste calculator. The other 2, inappropriate preventable hospital stays and avoidable emergency room visits, were just naturally important measures for the Commonwealth of Virginia. Next slide. On the high value care side, it's pretty straightforward. It's immunizations, it's diabetes care, and it's cancer screening rates. Keeping it simple. These are also all things that all of our health plans in Virginia are already including as part of their incentive-based contracts. So it was important to us in creating this dashboard not to create new measures that, were going to make it even harder on our providers here in Virginia. Next slide. And then the third one I mentioned, the infrastructure piece, and I would just focus on that second one. We rely very heavily on Virginia's all-payer claims database for the reporting and work that we're doing. So, and prior to this legislative session, our all-payer claims database was voluntary, and so it was very important that we see, a high percentage of claims being submitted. I believe that is changing as of last week, and all for the better. But it was very important to make sure that we had the data there. Next slide. I don't want to let you think that I was so successful in keeping our number of measures down to a minimum, because the dashboard is always going to be a work in progress. There are always going to be new things that we want to measure, or things that we knew from day one we wanted to measure, but we didn't have either a good measure or a good data source. And so we will continually be working. We have a future measures work group that is constantly talking about measures that we want to add to the dashboard. And here you just see a sample of those. Next slide. So then we come to the part of, okay, we have built consensus. We have identified a tool to create the baseline data that we needed and make a compelling story. We did the roadshow. We got people to look at those reports and to care. I should mention to you that that dashboard I was just talking about, that's actually funded by our Virginia General Assembly. That's important. That shows how important they think this is. It also conveys to stakeholders that work with the General Assembly that this is important. So all of that led to the place where we are now, which is, okay, now it's time to fix it. And how can we fix it, and what can we do? And we're really excited because we are at the jumping off point. And I want to take a second and thank Virginia's federally qualified health centers for kind of being our guinea pig, our first in line, early adopter. Their association raised their hand and said, hey, can you run dashboard reports for each of our centers? And then can you do a combined report? And can we start to figure out where we could do better? And so we have done that. They are starting to share some really exciting data. And I can tell you that data is being very well received at the federal level. So that is something that will be ongoing. We've shared reports with our state Medicaid agency and our state employee health plan. Both are fully on board to do a statewide initiative with us. As I mentioned, both our previous secretary and our current secretary have served on the board of this organization. And so we're excited to have both of them at the table. You can imagine that given their magnitude, they can leverage relationships in ways that we can't. And then finally, let me close with, hopefully very soon, you will be hearing from us about a large health system collaborative. We have had 6 of Virginia's health systems that represent over 1,000 practice sites come forward and raise their hand and say, we want to work on Drop the Pre-Op. We're interested. And that has been matched by the employer side of the house, where both the Virginia Chamber of Commerce and the Virginia Business Council have said, we want to work on this too. We understand that part of our role is to encourage the health plans to change the incentive structure. And so we're hoping that that health system collaborative working with the employer task force leads to meaningful change.